Simone has asked me to talk about one of those pieces of the complex puzzle that Marianne spoke to us about, called peptide receptor radionuclide therapy, and specifically who we should treat. And so we've already been introduced to this idea of the neuroendocrine cell, and I describe them to my patients as being like women in the best of possible ways. Nothing in this world happens without women, and the reason that it happens is because they coordinate things, and they do that through being great communicators. They're great talkers, but they're also very good listeners. And so the neuroendocrine cell sits at the interface or the surface of our body and takes chemical signals and then gives chemical signals to other cells which regulate how they work. It also talks to our immune system, very interestingly. Of course, anytime you get a conversation going, you need a way of cutting it off. And most, but not all, of these neuroendocrine cells own the same receptor called the somatostatin receptor, which stands for turning the body off effectively. It's like a revolving door that takes that naturally occurring hormone called somatostatin into the cell, which it delivers a message into the cell that really tells it to stop doing what it's been doing. And more than 30 years ago, a number of different copies, if you like, of that naturally occurring hormone were created. And many of the patients will know these because they've been on them, octreotide and pasireotide, lanreotide. These are called somatostatin analogues or copies. And they're conversation killers, if you like, for the cell. They stop it talking, stop it producing the hormones that it would otherwise produce. As I mentioned, the somatostatin receptor can be thought of as a bit like a revolving door that takes somatostatin into the neuroendocrine cell. And any kind of door needs keys, and those keys for this receptor are something called peptides. And we can stick a key ring onto those. These are things called collating agents, and we can stick some very attractive dangly bits on them, which are radioactive chemicals. Those radioactive chemicals can be for diagnostic purposes like gallium, or for therapy called lutetium. The key rings are called DOTA or NOTA, and some people call these DOTA scans, but I don't really like that term because the least exciting part of a key ring or a set of keys is the key ring. The most exciting part is the dangly bit, but the only way that it works is to have the right peptide, and the peptides that we use are octreotate or octreotide. And diagnostically, they go under these two terms that I call GATate, the dangly bit, the gallium, and the key, the octreotate, are the things that make it important. Commercially, that's known as net spot. And the therapeutic one, which gives off particles rather than rays that come out of the body and deliver therapy, is called lutetium DOTA octreotate, and we abbreviate that to lutate. So when you hear me say gatate and lutate, you'll know what I'm talking about. Commercially, that's known as Lutathera, and some of you will know it as that name. And this brings us to a concept we call Theranostics, which is really essentially changing the dangly bits that we put onto the peptide. So we use a diagnostic molecular imaging tracer, GATate, which we pair with a therapeutic agent, lutate. And it's designed to give the right therapy to the right patient at the right time. For therapy, we need particles which are delivering their energy inside the tumour. And for imaging, we need rays that come outside the body. That's what molecular imaging is about. And so the peptide enters into the cell, it gives off particles, and those particles damage the DNA, the genetic code that allows cells to both survive and replicate. PRRT really came onto the map in 2018 or 2017 with a publication that Marianne mentioned, the NETA-1 trial, which showed a really dramatic improvement in the outcome of patients who received the lutetium dotatate therapy, both in terms of how long it took for their tumours to progress on CT scans, and also how long patients survived. This was using 4 cycles of treatment every 8 weeks or so, based on somatostatin imaging with the older agent called Octreoscan. And this led to its approval in both North America and Europe, and it's now widely used throughout the world. But many of us in nuclear medicine, in fact, the first time that I used PRRT was almost to the day 24 years ago. In September 1996, we treated our first patient, who was actually also, by chance, one of my nurses in my department, who unfortunately had one of these neuroendocrine tumours, which I thought I would never see another one of, because they were so rare. You know, the world changes. Anyway, it took a long time for this NETA-1 trial to make people aware of how effective the treatment was, when in fact many people in the nuclear medicine world had been publishing trials back into the early 2000s with these agents. And all of those studies had shown really very consistent, reproducible results with significantly higher response rates than had been seen with the therapies that were available up to that time, and very long overall survival compared to the other therapies that were typically used in patients with advanced and progressive disease. One of the challenges in doing these clinical trials, however, the NETA-1 trial is what we call a randomized controlled trial, which is what the regulatory people really want to see is the high quality evidence. One of the difficulties in performing trials in this disease are firstly that it's relatively uncommon, and secondly, it's, as was mentioned, very heterogeneous. Many of the patients will have disease like this, very low-grade tumours. And if we look at 2 characteristics of the biology of these tumours, one, the somatostatin receptor that I mentioned, which is the GAT8 scan on the left here, or looking at glucose use.
Sorry for one moment. It's an announcement to wear masks here, so this I could not done with it. So please
That's
continue.
Right. Yeah, so the second scan is looking at glucose use. Most aggressive cancers will use more glucose to fuel their growth, but because these are very slowly growing, they tend to use very little glucose. Many normal or more aggressive cancers are routinely now evaluated with what's called FDG PET scans to look at their aggressiveness. And so in this particular patient, you can see lots of black dots indicating tumours in the liver, and some lymph nodes in the central abdomen, but no areas that are using increased glucose. The second patient here has a much more aggressive tumour, much more highly proliferative, as Marianne described it, with this Ki67 greater than 70%. And in this case, you see lots of black dots on the FDG scan showing lots of tumour deposits that are actively growing. But unfortunately, they've lost the somatostatin receptor as they become less like the cell from which they arose. This is a process we call dedifferentiation. They cease to be like the cell from which they came. And so if we look at the GAT8 scans in these 2 patients, one's strongly positive, one's negative, and the one we can see, we can treat. The one we can't see, we can't use PRRT because the target for that therapy is not present on the cells, even though the cells are there and actively growing. The FDG tells us that we can't use the PRRT in the one on the right, and that's a patient we probably need to use chemotherapy because their outlook is going to be poor if we don't control their disease. In the early days, and I gave a talk to a Scandinavian group a couple of weeks ago, and I was introduced as the crazy guy who stood up at the MENETS meeting all those years ago and said that we should be treating patients with more aggressive disease with PRRT as long as the target was there. And that was based on our early experience of using this therapy. Because of the requirements in our particular environment where we have to treat only patients who had failed all other therapies. Many of our patients had the quite FDG avid disease, had the more aggressive type of disease, and the majority of our patients had what we call G2 tumours rather than the early G1 tumours, which had traditionally been used. In fact, 58 out of the 68 patients we first treated with lutate had been shown to have progression within 12 months, which is quite rapid for these low-grade tumours. And this was because we have a compassionate use criteria in Australia, which meant we were only treating the worst patients, not the best candidates for this treatment. It's very important in asking the question who we should treat. I agree entirely with Marianne that we should treat patients, not scans. That if you're asymptomatic and your tumour's not growing, we can't make you feel better, and we can't make a tumour that's not growing stop growing because it's not doing that already. And so the scans and following patients with scans serially can be very helpful to reassure us that the disease is very, very stable. And this is a patient we followed for a number of years before they started to progress. However, the scans do tell us very sensitively when a patient is progressing. As you can see, from late 2012 to early 2013, this patient had more black dots appear and the tumours got bigger. And this is a patient who was asymptomatic but clearly had progressive disease, and we need to think about treatment in this patient to stop that progression. We also know from the scan that the patient's suitable for PRRT because there's very strong expression of the receptor on their tumour cells. Sometimes as patients and caregivers, it's very hard to understand why we don't rush into treatment. When you see all these black dots on a patient, you say, I've got all this cancer inside me, surely you should treat it. But in fact, we know that it's very hard to treat tumours that aren't growing, cells that aren't dividing are very resistant to the effects of radiation. So we'll often watch a patient for a number of years or months in some cases until there's clear evidence that they're growing. And when they start growing, as you can see here, that the number and blackness of the dots has got greater, that's the time that we come in with the treatment. And as you can see, that following the treatment, we see those dots getting less intense and smaller. And the reason that they get smaller is because they are growing, whereas normal tissues, which are very stable and not dividing, are very resistant to the effects of radiation. And we see that actually on the scan, that the pituitary gland and the thyroid gland, which also have these receptors on them, are not damaged by the radiation because they're not growing. In fact, when we measure the hormones that they produce, they continue to produce them in normal amounts. So who should we treat with PRRT? I pointed out that target expression is needed, but also the intensity of that uptake or of that signal matters, and I'll show you why. As Marianne pointed out, we need to determine the goal of treatment, and that's done in partnership with the patient. Is it for symptom control, or is it for to try and improve or prolong survival in a patient? In terms of symptom control, we know that hormonal control can occur quite rapidly, and therefore we don't need to have progression to justify treatment. And this is often the case because hormone secreting neuroendocrine tumours often are slow and have very little regression when we treat them with PRRT. It's not the purpose of treatment to get them to shrink, but rather to stop them producing hormones. We know that the indication for this is generally the failure or intolerable side effects from medical therapy like somatostatin analogues, or prolonged loss of quality of life, which provide us a rationale for treatment of these patients. But in other patients where the tumour is starting to grow, we need treatment for cancer control. We can do that either on the basis of demonstrated progression of the disease on imaging, that it's clearly growing, or where there's a very high likelihood that the tumour will progress based on the pathology that tells us it's a higher grade tumour. We also know, as I showed you before, that where there's FDG avid disease, a standard PET scan shows that glucose use. That's a pretty good clue that the tumour is likely to grow. And so we use that as one of our criteria to select patients for treatment. In terms of the intensity of uptake, even from the earliest work by the Erasmus group in Rotterdam, who really pioneered this therapy back in the early 1990s, they showed that the more intense the uptake on the scan, the more likely you were to get tumour shrinkage. And that's because what we see on the scan translates very much into what radiation dose the tumour gets from PRRT. And this really matters if we can get a very high dose into the tumours. The top corner, left-hand corner of this slide shows the amount of radiation delivered into 3 tumour deposits that we've measured over the course of 4 treatments. And you can see that, well, you may be able to read the number there is about 120 grade. To put that into perspective, that's about twice the radiation that we normally deliver into lung cancers or head and neck cancers or other cancers with external beam radiotherapy. And of course, if you dump that much radiation, you'd expect you'd get a good response in the tumour. And you see, even during the course of treatment, the number of and extent of black dots on the scan got significantly less, indicating a very high response. But they also got less intense. And if we look at the top right panel at the far side here, that the tumours got very much less radiation with each cycle of treatment because of that reduction in intensity. And because there was less going to the tumour, there was also more progressively going to normal tissues. And so there's always this balance between how much radiation we're giving to the tumour and how much we're giving to normal tissues. What goes to normal tissues potentially causes toxicity to the kidneys or to the bone marrow, which forms our blood cells. In terms of controlling symptoms, PRRT can provide benefits well in excess of the shrinkage that we see. This is one of our patients who was 77 years old. He was in intensive care, secreting a very large amount of insulin, which is, is used for the treatment of diabetes because it lowers our blood sugar. And if you have an insulinoma, you produce too much insulin and the glucose levels become very low. And so he was being supported with heavy medications to raise his blood glucose. After 4 cycles of PRRT, he was at home on hardly any medication at all. And you can see that there is a slight reduction in the extent of his disease, but despite only having a partial scan response, he had a complete symptomatic response, and that happened much more rapidly than we saw shrinkage. And in fact, the tumours continued to shrink over the next 2 years, during which time he came off all medications. And I happened to see him last week. He came into the department aged 85 years old with his son, and he reported that all his friends who'd come to ICU to wish him farewell, that he was close to death, were unfortunately all dead. And he was a bit surprised that he was still alive. In terms of the relief of symptoms, bone pain is another thing that can be very usefully treated with PRRT. This is a patient of mine who first treated in February 2008. She was wheelchair bound at that time. Within a couple of weeks of her first cycle of treatment, the pain went away. And by cycle 2, she was out of the wheelchair, walking again, and she was working within a year. And she's remained in good health despite not being cured and having an abnormal scan to this day. A really excellent symptomatic response and excellent quality of life. So in terms of selecting our patients to treatment, as I've pointed out, the presence of the somatostatin receptor is very important. And the proportion of patients who have that receptor tend to decrease as the grade of tumour across the bottom scale increases, gets less. The glucose use gets up. And so we have actually 3 populations of patients: those who have the somatostatin scan that's positive, the green zone, they're the ones that have traditionally been treated with PRRT. The red zone where only the glucose is used and there's no somatostatin receptors, we can't treat them with PRRT. And an area in the middle where both are expressed in the same patient, in the same lesions, they're the ones that we think that are most important to treat. And the reason we think they're most important to treat is because they're more sensitive to the radiation that we can deliver. And the outlook, the prognosis gets worse as the grade gets higher. So in that zone, the prognosis is getting worse, but the likelihood of benefit and response is increased. And so we use the colors advisedly. Your reds, don't think about PRRT. Green, you can go if you want. Amber, get going quickly because you haven't got much time. If you doubt that the more aggressive tumours respond to PRRT, this is the glucose scan. You can tell that by the high use of glucose in the brain. The black blob at the top of the body there is the brain, which likes glucose. So do tumours, and you can see that in the first two scans, while the patient was receiving chemotherapy, which is the traditional therapy for these more aggressive tumours, it clearly progressed. And after 4 cycles of PRRT, you can see that all that glucose use has stopped in the tumour in this particular patient. And at the same time, those somatostatin receptor expressing tumour deposits, which we see on the GATATE scan, the gallium nitrate scan, very black, lots of spots in the liver and in the pancreas. And after treatment, just a couple of small deposits, one in the liver and one in the pancreas. And again, this patient is still alive today. He still has disease and we're still treating him. We've, and other groups, the first pie chart is from my centre, the middle one's from Germany, and the last one is from Scandinavia. All of them showed in this high-grade group of G3 tumours very similar response rates, around 35 to 40% of patients getting shrinkage of their tumour. What doesn't necessarily happen with these more aggressive ones is it's not necessarily as long lasting. And so the higher the grade of the tumour, the quicker it comes back and the more aggressive we have to be. And often now we're combining PRRT with chemotherapy to combine or to treat both the well differentiated or better differentiated and the more aggressive components of the disease. In some patients, we're even using it up front as the first line of treatment. This is actually a family physician who lives in country. She didn't want to have chemotherapy because it would really disrupt her practice, and she elected to have PRRT as her first treatment. These are the first 3 cycles of treatment. As you can see, the dramatic reduction in the extent and intensity of disease. In fact, she felt so well, she decided to take a holiday between a 3rd and 4th cycle of treatment in France. This is a patient with, again, a very high grade or significantly high grade tumour. And you can see after the first 4 cycles of treatment, the liver, which was densely black, packed with tumour, came back almost to normal. And by monitoring this patient with serial follow-up scans, the GATATE scans, we're able to identify when his disease was coming back. And each time we saw disease recurring, we gave him additional cycles of treatment with very good response or control of his disease. And this is really the more important aspect of than that slide before. This is that man who, during the course of the treatment from 2012 to 2015, he travelled the world between each of the cycles, and he sent me back emails with pictures of him in various exotic parts of the world. And he shared this analogy with me. He said, when I came to you, I thought that there was only one part to the bottom, which was off the edge. And you've taken me down the donkey trail, which is much slower and scenic. But even though the destination he knew was going to be the same, he really enjoyed the ride. And so whenever I'm talking to patients, I always, I like to show them the scans, but I also try and remind them what's important. The scans, the GAT8 on the scan on the top and the FTG on the bottom clearly look better. But the thing that really was important to us was that the patient in those scans was able to go from being very, very unwell to riding behind the Tour de France in 2015. And he's now the president of the Unicorn Foundation in New Zealand, which is one of the Inca group of organisations. And so that's an incredibly satisfying outcome for this treatment. And so with that, I'll thank my team who make all that possible, and also our funding bodies who also support us very much. And I've got the Unicorn Foundation down there in the bottom left. We've now changed our name to Neuroendocrine Cancer Australia to get some better brand recognition. And I'm very proud to be a director and chair of their scientific advisory board. And they do a wonderful job, as all the Inca agencies do. So with that, I thank you very much for your attention.